Today we're diving deep into a really common problem, recurrent urinary tract infections. But we're going to look at it from a pretty unique angle, as a masterclass in how an entire healthcare system can use data-driven guidelines to manage an everyday issue and, at the same time, fight a massive global threat. So, let's get into it.
First, just to set the stage, look at this number, 50 to 60%. That's the lifetime risk for a woman to get at least one UTI. We're not talking about some rare disease here. This is a huge public health issue. And that sheer prevalence is exactly why having a smart, structured approach is so absolutely critical. All right, here's how we're going to break it all down today. We'll start by defining the disease itself. Then we'll move into diagnostics, the bugs that cause the trouble, treatment strategies, the bigger public health picture, and finally, the serious complications we're all trying to avoid. Okay, Section 1, defining the disease. And we're going to start with what is a really fundamental shift in how we even think about classifying these infections. So, what do we actually mean by recurrent? Well, it's not just a feeling of getting UTIs a lot. There's a very specific clinical definition. We're talking about 3 or more infections with symptoms in a single year, or 2 episodes in just 6 months. Hitting this number is the trigger. It's the point where we stop just treating individual infections and start thinking about a long-term management plan. Now, this right here is a brilliant and incredibly important shift in thinking. The old way was to label the patient as uncomplicated or complicated. The new paradigm, though, it labels the illness itself right now. Instead of asking, is this a complicated person, it asks, how sick is this person today? And focusing on current signs like fever or chills is what tells you exactly what to do next. It's practical, it's immediate, and it directly guides your treatment decisions. Section 2, Diagnostics and Identification. Because getting the treatment right starts with getting the diagnosis right. This list is a perfect example of what we call antimicrobial stewardship, basically using our tools wisely. You'll notice a urine culture isn't a default for every single person with symptoms. No, it's reserved for these specific higher-risk scenarios. This targeted approach means we're not over-testing or over-prescribing for simple cases, which is a huge deal. And of course, any test is only as good as the sample you get. It sounds really basic, but this clean catch technique is everything. It's the whole garbage in, garbage out principle. Every single step is designed to make sure what ends up in that cup is actually from the bladder and not just contamination from the outside. You have to get a clean signal to make the right call. And once that sample hits the lab, oh man, technology has been a complete game changer. This thing, MALDI-TOF mass spectrometry, it's like a high-speed fingerprint scanner for bacteria. What used to take a full 24 hours to identify a pathogen can now be done in less than an hour. That kind of speed is revolutionary. It means getting patients on the right antibiotic faster than ever before, which leads us perfectly into Section 3, Pathogens and Resistance. So, how do you make sure you're picking the right antibiotic? Well, it's not a guessing game. It's all about the data. Now, in a hospital, the cast of characters gets a little more diverse. E. coli is still the main culprit. You can see it there taking up almost half the chart. But other bugs like Enterococcus and Klebsiella start to play a much bigger role. This microbial diversity is precisely why getting a culture in these sicker patients isn't optional. It's essential. And this is the heart of the whole evidence-based model. This table tells you everything you need to know. Look at nitrofurantoin. E. coli resistance is super low, less than 5%. That's why it's the first-choice drug for a simple bladder infection. Now look at trimethoprim. Resistance is way up, over 25%. That's why it's been knocked down to a third-choice option. The data from national surveillance directly informs the guidelines. It's that direct. Okay, Section 4, Treatment Strategies. Let's take all this theory and see how it actually plays out in the clinic, with a couple of case studies. So let's meet our first patient. She's a 68-year-old woman, and this is her 4th UTI in the last 10 months. She's got all the classic localized symptoms but no fever, and her urine dipstick is positive. This is pretty much the textbook definition of recurrent, uncomplicated cystitis in a postmenopausal woman. All right, so how do we manage this? It's a multi-step approach. Step 1, of course, you treat the infection she has right now. And based on the guidelines, that's nitrofurantoin. But step 2 is the real key here. You have to address the root cause. For her, that's the lack of estrogen. So you start topical vaginal estrogen to improve the health of the whole area. Long-term antibiotics, that's way down the list, a last resort, only if everything else fails. It's a root cause first strategy.
Okay, now for a completely different kind of case. We have a 2-year-old girl with a high fever, she's irritable, and her urine test is positive. Now, the symptoms are pretty vague, but a high fever plus a positive urine test in a child this young, that immediately makes you worry about acute pyelonephritis. That means the infection might have traveled up to her kidneys.
So the protocol for kids is, as you'd expect, very buttoned up. The #1 goal is to prevent any permanent damage to those developing kidneys. A culture is non-negotiable. You start treatment right away. But, and this is huge, you also schedule a mandatory kidney and bladder ultrasound to look for any underlying problems. Every single step here is designed to be as thorough and as safe as possible.
So far, we've really been zoomed in on individual patients. For Section 5, I want to pull the camera back and look at the huge public health and surveillance system that makes all of this work. See, one of the secrets to this model's success is how integrated it is. Labs are required by law to report what they call BRMOs, highly resistant microorganisms. Think of these as the superbugs on the most wanted list. That data doesn't just sit in a file. It gets fed into regional care networks. This connects everyone, GPs, hospitals, public health officials, so they can mount a coordinated defense against resistance threats.
And that brings us to our last and maybe most important section, complications. Why does all of this matter so much? Because when things go wrong, the consequences can be incredibly serious. The risks are laid out pretty clearly here. In the short term, you worry about the infection moving up to the kidneys. That's pyelonephritis, or even worse, getting into the bloodstream, which is urosepsis and is life-threatening. But the long-term damage is just as scary. Repeated infections can cause permanent kidney scarring, which can lead to chronic kidney disease and, for some people, a lifetime of chronic pelvic pain.
I think this statement just perfectly captures the entire philosophy. Managing these infections isn't just about following a clinical flowchart. It's treated as a public health doctrine. It means every single time a doctor writes a prescription, they are weighing two things: what's best for this one patient in front of me, and what is our collective responsibility to fight antimicrobial resistance for everyone.
And that really leaves us with a final big question to think about. We've just walked through a model that is incredibly disciplined, completely data-driven, and highly integrated across an entire system. As we stare down the barrel of rising antibiotic resistance all over the world, you have to wonder, is this the blueprint? Is this the future for how we're going to have to manage all infectious diseases?